guest speaker for this evening, just allow me to briefly introduce myself. So I'm a professor of medicine and a rheumatologist based at the University of Sydney and Royal North Shore Hospital in Sydney. And it's a pleasure to have an opportunity to speak with you this evening. Please feel free to type something in the chat and hopefully I'll see that somewhere. All right, but again, great to be with you this evening and really looking forward to the opportunity to share a little bit about osteoarthritis and also what we're doing in this space and hopefully stimulate some questions and hopefully enhance your understanding of this very prevalent disabling disease. All right. Most of my support for the work that we do comes from the National Health and Medical Research Council and also from Arthritis Australia. And I also received some funding from Osteoarthritis and Cartilage, from Up to Date, and from the National Institute of Health. And I do some consulting work for some companies that I'm not going to be talking about during the course of this evening's presentation. I would first like to start by acknowledging the traditional custodians of the land and paying my respects to elders past, present, and emerging. Okay. All right, so this gives you a brief outline of what I'm going to go through the course of this evening's presentation. I'm going to talk about where treatment currently stands for osteoarthritis, how that's different from what's currently recommended, look at ways that we can hopefully enhance evidence-based care, and then at least briefly touch upon some future directions and some of the research that we're doing in this space to hopefully enhance care and management of this problem, and then open it up for your questions. And again, really looking forward to that interaction. So please do feel free during the course of the presentation to use that chat facility. Now, through the course of this evening's presentation, occasionally I'll have a slide that looks a little bit like this, that'll either have a website on it or a QR code that'll allow you to scan to get further information about something that I'm speaking about. So please feel free to have your phone handy to either use that to scan the QR code or to take a photo of the slide. I'm very happy that this recording is being, the presentation is being recorded, and I'm very happy also to share the slides after this evening's presentation. So please, again, I will try and announce those slides so you know when they come along. This is the first of those slides, but again, I'm going to show this slide again, so don't feel the need to drag your camera out right now. All right, now, I think part of what I want to focus on is some of the misconceptions that abound around osteoarthritis, and you've probably heard many of them. And so this is just an example of some of them, and I'm not going to go through all of them, but I will touch upon some of them as we go through the presentation. Some of the misconceptions include that joint pain is always a sign of damage, but pain can occur even in the absence of any damage to the joint. Joint pain only gets worse with time, but for the vast majority of the people who have osteoarthritis, the trajectory is actually pretty flat. It's not one of insidious progression. Again, a lot of people believe that too much activity damages your joints, but honestly, graduated load-bearing exercise has benefits. A lot of people, again, believe that exercise-based interventions can't help your damaged joints, and the converse, to be honest, is true. And that some people believe that surgery is the only cure for joint pain. But for about 1 in 4 people who has a knee replacement, pain is no better than it was preoperatively at 12 months after the surgery. So again, it's not the cure that I think a lot of people believe it could be. So let's touch upon some of the other common myths. So a lot of people believe that the disease is equal to the structural change that goes on in the joints that equals the symptoms. And so part of that is true. And so the disease itself is what we call a whole joint disease, meaning any of the tissue structures within the joint, the bone, the cartilage, the lining of the joint, what we call the capsule, the muscle, the ligaments within the joint, can all be affected in the context of osteoarthritis. So that's the disease. It's much more important for me as a clinician and for you as someone who's living with this disease about the illness, namely the lived experience of living with osteoarthritis. And not surprisingly, what we see as structural changes, both on X-ray and MRI, and what you experience as symptoms often doesn't necessarily mirror one another. And so for me, this is what matters. And oftentimes it doesn't necessarily mirror what we see on imaging. This is an incredibly common problem. About 1 in 8 adults, about 3 million Australians, about 500 million people around the world are affected by osteoarthritis. The prevalence is going up. Okay, so we already know that a large proportion of the world's population has this. It accounts for a substantial amount of our healthcare expenditure, in large part because of the costs related to elective joint surgery and recovery from that. And it's also a huge contributor to global disability. So it's in this context where we know that we have huge unmet needs in terms of pain. We have a lot of treatments that generally have small effects, and for many of them, toxicity is a concern. And more often than not, we also have a health system that pays for volume, not quality or value. Okay. And so for you as a consumer of healthcare, as a person who's living with osteoarthritis, all of these are a problem. And it's obviously something that we're trying to redress as we develop new treatments to help you with your pain and your disease, but also to redress some of the counterintuitive ways our healthcare system looks after you. Let's start with the way the disease is diagnosed. So a lot of people believe that diagnoses are made based on an X-ray, but again, that's a myth. So the most common ways we diagnose this disease is based on a constellation of symptoms, so namely your pain, your function, and certain signs that we can find on examination. And whether you live in the UK, in Europe, or America, these are the criteria that are universally used. We don't need an X-ray nor an MRI to diagnose this problem confidently in the vast majority of people. Now, the reason I emphasize that is oftentimes when a person gets higher order imaging, particularly things like an MRI, we find things that may make you concerned, but are really just part and parcel of the disease of osteoarthritis. But that concern on your part may lead you to want to have surgery, such as an arthroscopy, that doesn't necessarily help with either the underlying disease or your symptoms. So ideally, when we see a person that has osteoarthritis, we try and approach them from a number of different directions to develop a plan that's personalized and driven according to your goals and measure and monitor how we go. So when we do that holistic assessment, there are a number of different factors that can influence your symptoms, but also your approach to how we might treat the disease. And so for me as a clinician, this is what I try to attain when I review someone that has osteoarthritis in an effort to better understand the impact that this disease is having for them. Now, this is probably going to seem a little bit like academic semantics to you. And if that's the case, I apologize. But at least for me, I think it's important. So a number of the terms that are used to describe osteoarthritis, like bone on bone, wear and tear, and degenerative, are widely used. But I'm going to explain why they shouldn't be. So firstly, those terms degenerative and wear and tear, every joint has capacity for repair. So it's not just a one-way street. What happens in the context of osteoarthritis is that breakdown processes overwhelm the joint's capacity for repair. So it's in that light, ideally, we should be calling this wear and repair if we're just focused on the pathology that occurs in the context of osteoarthritis. Why do those terms matter to me? Well, firstly, this is a study that was done on people who were having their joints replaced. And those terms were used widely by people who had heard these from their clinicians prior to the surgery, wear and tear, bone on bone. And as a consequence of those terms, these people felt that their joint was vulnerable. And as a consequence of that, avoided activity and thought that surgery was the only option. So again, these terms have an impact on your beliefs and your attitudes towards treatment, which, as I'll come to later, this type of approach to care is not what we would be advocating for. So what we're trying to do is move away from the communication style that current clinicians use, which is what we call an impairment-focused framework, where essentially you've got broken parts, you need to be dependent on healthcare. as opposed to what we should be trying to do for people that have osteoarthritis, which is about basically empowering you with the knowledge you can use to look after your own disease with helpful beliefs and behaviors, which I'm going to come to in greater detail in a moment. If you want to hear a little bit more about what the descriptors should be and how we best communicate about osteoarthritis, this is a discussion that Sam Bunsley had on our Joint Action podcast relatively recently. So another misconception is that everybody's disease follows a steady progression ending in joint replacement. Now, whether you live in the UK, which is where this study came from, or the US, which is where another trajectory study came from, for the vast majority of people, if we follow them for long enough, and we're looking at a rating scale for pain, for the vast majority of people, the trajectory is relatively flat. A small number of people, it gets better. A small number of people, similarly, it gets worse. But you can see, by and large, those lines are relatively flat over a long period of time. Message being that the trajectory of symptoms for most people is not one of inexorable decline. It's not uniformly going to get worse. And by and large, for most people, that trajectory is pretty flat. Now, just to complicate things a little bit further, this is a schematic. Okay, so this is hypothetical. When a person first develops disease, what typically happens as far as the pain is concerned is they have intermittent symptoms. And between those symptoms, they're generally pain-free. Over a reasonable period of time, they may start developing a chronic background pain, and the episodes become longer, and the interval between those episodes somewhat shorter. And then if they were to progress to chronic disease, they have the background constant pain, but again, those episodes are still occurring with little, if any, time between them, and much more severe in terms of the severity. Now, why do I emphasize this point? Well, at least in analyses that we and others have done, it's the episodic pain, the flares, if you want to call it that a lot of people with osteoarthritis find most disabling, primarily because it's oftentimes not something they can readily predict when it's going to happen and the impact that it has as a consequence of that. Again, another common misconception is that the only way this disease can be managed is through joint replacement. But what I'd like to emphasize to you is that it's really the minority of people that have osteoarthritis have a joint replacement in their future. So 10% or less end up with either a hip or a knee replacement. So a joint replacement is definitely not inevitable and not necessarily part of what we see happening for most people that have osteoarthritis. Now, ideally, what we should be doing more of is prevention, impacting progression, but at present, generally what we do is focus on palliation. So basically give people anti-inflammatories, and when that doesn't work any longer, have their joints replaced. I'm going to talk a little bit more about the role of each of these and the opportunity to do that. Now, firstly, a lot of people believe that disease is inevitable if you live long enough. But again, it's a myth. And again, disease can be prevented if given an opportunity to do so. So if we look at the reasons why people develop osteoarthritis, we can see that about 20% of people do so by virtue of an injury, particularly a tear of their cruciate ligament or the meniscus. About 45% of it, at least for knee osteoarthritis, relates to excess weight. So both of these are eminently preventable from a public health perspective, and we should do more about them. And so we're doing a study at the moment focused on preventing disease by targeting obesity, and there's a similar study in the US where they're doing a similar approach, but targeted towards individuals who've just had an injury. Now, why are we seeing increasing numbers of people who are overweight or obese? Well, in the first instance, the proportion of time that we're spending being sedentary, if you look at time going by, is going up. So the average hours per week being sedentary, you can see at least now, is close to 40 hours per week. This is daylight hours. So that increased proportion of time being sedentary means that we're burning fewer calories. Now, there's lots of reasons why that might be the case, and this slide's obviously a little bit tongue-in-cheek, but for many people, some of those behavioral changes that we'd like them to undertake in terms of getting more active are challenging and they're not necessarily overly enthusiastic about pursuing it. At the same time as we're becoming increasingly sedentary, we're also taking in more calories. And that's pretty much irrespective of where you are around the world, is that the number of kilocalories per day is gradually increasing. So that combination of reduced expenditure, increased intake, is leading to the position now where approximately 2/3 of Australians are overweight or obese. Now, you might think that, we're a hell of a lot better than the US, but it's not by very far if you look at these particular statistics. So in an ideal world, we do a lot more about reducing the proportion of people who are overweight or obese through public health interventions. And so we know that there's a lot of, I guess if you want to call it obesogenic environmental factors contributing towards why we're gaining excess weight. So in that light, what we've done with some colleagues in the US is set about to see if we can actually prevent the onset of osteoarthritis by recruiting a population of people into a 48-month healthy lifestyle program. So this is for people who live in Sydney. And again, I apologize. I think a large proportion of the people who are on the line are probably in South Australia. But if you know people in Sydney who might be interested, women over 50 with a high body mass index, who've had little or no knee pain, so we can prevent the onset of osteoarthritis, who want to be a part of a 48-month healthy lifestyle program, we would love to hear from you. So again, that's the QR code. And again, I'm happy to share the slides and the recording after tonight's presentation. So let's move on to management of the disease. And I know for many of you who are experiencing osteoarthritis, this is a huge challenge and something, again, I'm very happy to take questions about, but hopefully through the course of this evening's presentation, some of what I say will be enlightening in this regard as well. So this is a range of common, what we call non-communicable diseases that are readily found in today's community. And this axis looks at the percentage of appropriate care being received. And for osteoarthritis, basically about 40% of people are receiving appropriate care, so that we know for a large proportion of people, they're not being asked about their pain or function despite osteoarthritis being the presenting problem. About 2/3 of the people are not being prescribed what we call the core treatments of getting strong, staying active, and losing weight if they're above a healthy weight. About 2/3 of the time, they're being prescribed the wrong drugs. And so there's lots and lots of room for improvement, but what we're seeing is lots of what we call low-value care or too much medicine. MRIs abound for a disease that can be diagnosed clinically. 20% of people who have osteoarthritis are on opiates, and these cause more harm than benefit. A large proportion of people are still getting arthroscopies for their knee osteoarthritis, and essentially that's a procedure that most guidelines recommend strongly against because it doesn't help symptoms and it accelerates the underlying disease. Part of the problem here is that there are huge variations around the care that is being received in Australia. And again, I may be misspeaking, but I understand many of you are from South Australia. South Australia is a case in point where a much larger number of people are receiving these types of surgical procedures than most of the rest of the country, suggesting that that variation may be disproportionate to the care actually needed for this particular type of problem. So this high variation of low value care is a particular problem that we see a lot of in osteoarthritis and something ideally we should be doing more of. So how should we be managing this problem? Well, firstly, this is the College of General Practitioners guidelines that we brought out a few years ago, and we're in the process of updating that as we speak. Ideally, we assess someone holistically, consistent with what I spoke to you about a moment ago. We make the diagnosis clinically, and then we tailor a plan to you as an individual, focused on what we call the core treatments. So that's education, self-management, weight loss for those who are above a healthy weight, exercise and physical activity, review of medications, mood and sleep management, because we know that that can complicate your pain experience, using topical medications, walking aids, and assistive devices. Where needed, we use analgesia and joint replacement surgery, and I'll come back to where we might consider that in the journey. But a lot of what we see here in red are things that we know are occurring commonly in clinical practice, and most guidelines would recommend strongly against their use. So again, if this is what you're seeing, really try to shift from the red into the green where possible. So what we're trying to do, at least in terms of trying to improve care throughout Australia, is do a lot more of what we call multidisciplinary management, where we get people to engage in physical activity, exercise, weight management, and education. And there's a number of these programs that are available. This is a program that we established in New South Wales and is available in every public hospital in New South Wales. This is another program focused on exercise, another program run by Medibank, which is diet and exercise, and a program that we established with Ramsay Connect for remote delivery of a multidisciplinary program. So there's lots of these programs that are available. Many of them are paid for by private health insurers. Some of them you can pay for out of pocket. We know that they work, they're cost effective, they reduce the joint replacement requirement, and they're available in a variety of delivery methods. The big problem, and I'm going to come back to this because I know this is a big problem for many of you, is the limited reimbursement, leading to lots of inequity and lots of large out-of-pocket costs. So that's a huge problem. And again, something we're trying to advocate strongly for nationally. Now, I spoke to you a moment ago about the need for us to personalize care. So ideally, in the context of osteoarthritis, we should be trying to manage the individual, and everybody's disease presents somewhat uniquely. So how might that manifest when we're trying to personalize and target care for the individual? So when we see someone who presents with osteoarthritis, we assess a range of factors which theoretically are modifiable. For everybody, as I mentioned a moment ago, who has osteoarthritis, these are the core treatments: education, self-management, physical activity and therapeutic exercise, which basically means strengthening exercise, and maintaining a healthy weight. Depending upon the presence of these, there are other things that we ideally should do and emphasize in terms of tailoring the treatment. So strengthening for muscle weakness, reducing weight for those who are above a healthy weight, cognitive behavioral therapy for poor mood or sleep, bracing and orthotics for joint malalignment, and pacing and walking aids for these joint overuse or injury or temporary flare-up. So there are lots of different options for personalizing the care and targeting this to the particular individual that don't necessarily just mean you had to have surgery. So ideally, this is how we should be delivering care. So what's happening? Well, one of the things is that many people believe that glucosamine or chondroitin can cure my osteoarthritis. But again, despite what you may have read, that similarly is also a fact or a myth. Now, I know for many of you, there's a lot of interest in taking supplements, and there's a lot of advertorials and testimonials. And I'm here to try and give you some real evidence based upon the existing literature. We know that over the course of the last couple of decades, the number of people who are taking glucosamine or chondroitin has decreased. Number of people taking fish or krill oil has actually increased. And I think it's incredibly important that for you as a consumer, you have the best evidence available to you. So this is a systematic review we did a few years ago. And again, we're in the process of updating this. So there should be an updated version of this relatively soon. You know that in the context of osteoarthritis, there's a whole range of different things that some people advocate for that might be helpful for your osteoarthritis. Essentially, this is a figure from a systematic review, and everything that lies to the left-hand side of this dotted line suggests it has an effect over and above what we might see with a placebo. So basically, glucosamine, we can't tell it apart from a placebo. There are a number of different supplements, however, that have a number of different trials suggesting that they may have a beneficial effect, including MSM, pycnogenol or marine palm bark extract, curcumin, and boswellia. And so on the back of this, we've now got a line of research focused on looking at these combination of supplements to see if we can develop a better evidence base around their use so that you can be better informed about the management of your osteoarthritis and potentially use these with an evidence-informed choice about that. So again, just to emphasize, this is an infographic which might make it a little bit easier. Those where we found that they had a large effect were curcumin, boswellia, and pycnogenol. small or no effect. There's a whole range of them, but I really just want to emphasize that on that list, glucosamine and chondroitin were down here. So these are the ones that we're focused on in the research that we're doing on the back of the fact that there's good evidence to suggest that they may actually have a good effect. So we've commenced a trial. In fact, as of today, I think we've actually recently finished recruitment for this trial. So this, just ignore this QR code for now. But this is a trial where we're using this combination supplement for people that have knee osteoarthritis. If you would like to access that, this is an enterprising company that has put together that combination of ingredients into one capsule that you can access online, either using that QR code or through the website, jointactioncare.com. So again, this is the same combination of ingredients that we're using in our clinical trial that is actually available online now through a company that's independent of us. All right, so what does the future look like for people that have osteoarthritis? One of the areas where a lot of people are doing a lot of work is in the area of what we call disease-modifying osteoarthritis drugs. And so these are essentially therapeutic agents targeted towards different parts of the joint, which will likely be an injection into the joint to help repair the joint damage and help to relieve your symptoms. So there's a whole range of different ones being developed, targeted to cartilage, targeted to the lining of the joint, what we call the synovium or the inflammation, and also some targeted towards the bone itself. These are in various stages of therapeutic development. A couple of them are in phase 3 and will go to regulatory agencies in 2026. And I'm optimistic that at least one of those will get approved, at least by the FDA in the US, for use for disease modification. So again, just to emphasize, these will be injections targeted to be delivered into the joint to help repair the joint tissues, and by virtue of that, also help to relieve your symptoms. Part of the challenge with doing trials like that is that everybody is different, and that's what we call subgroups or phenotypes of osteoarthritis. Now, the most common routes to develop osteoarthritis in the modern world is that of injury, or that related to excess weight, or essentially a metabolic type phenotype. But there's lots of different ways you can get there, either through family history, aging, postmenopausal, mechanical overload, or inflammatory. So what we're trying to do now is use that knowledge to target treatments more appropriately so that we can recruit people with particular mechanisms at play and use what we call a TheraType technology to treat people with the agents that I showed on the previous slide, so that they're targeted towards cartilage or inflammation or bone or so on. One of those agents that we're currently in the process of testing is an agent called pentosan polysulfate. And we're recruiting for this study as we speak. Again, if you're in the Sydney area, this might be appropriate for you to scan, but if you're not in the Sydney area, it's probably going to be difficult for you to attend 4 visits over 6 months in Sydney. But again, this is targeted towards the structure of the joint and relieving symptoms, and it's a clinical trial that we're currently recruiting for. Now, very happy to open it up to your questions, so please feel free to start typing things into the chat box. I'm really looking forward to that interaction. But again, just to emphasize, this is a complex disease that makes up of a number of different phenotypes or subgroups. It's very prevalent and is a leading cause of disability in our community. Prevention is possible, but it does require typically some behavioral change. And we need to treat everybody as an individual. And there's lots of different options for us to treat this from a public health perspective. And I'm optimistic about what the future looks like. Now, for the next couple of slides, these are a little bit of, hopefully a little bit more information if you want to glean a little bit more information about the disease. So we run a podcast where we get international experts in this space to answer questions which we think are hopefully relevant to people who are living with osteoarthritis. including what type of exercise, how to exercise, what supplements, should you have your joint replaced? Should you have an arthroscopy? Should we use opioids? So there's a lot of different topics that I hope would be informative to people who are living with osteoarthritis. So that's the Joint Action podcast for those of you that are interested. For those of you that want to access resources that may help in the management of the disease, we have this website called the jointaction.info website. And particularly if you go to what can I do, it gives you resources about what you might be able to do to help manage your disease. And then under the where can I go tab, it gives you a list of resources that are available, most of them throughout Australia, that might be able to help you with the management of your disease. So again, that's the jointaction.info website. Very recently, we launched an update for our My Joint Pain website. So we're now calling it My OA, and this is done in collaboration with Arthritis Australia. And so for those of you that want to go along to that, it's a freely available resource, has a lot of information about different types of treatment and tools that you might be able to use to help monitor your disease. So that's the My OA website, myoa.org.au, for those of you that would like to go on and learn a little bit more about how to manage this disease. All right, now, one, I think, relatively final thing, I'm just going to get on the soapbox for 2 seconds. Now, we're fortunate that we live in a relatively democratic country, and we have what appears to be a federal election coming up relatively soon. And I'm assuming most of you vote. And if you don't, I would strongly encourage you to do so. Now, arthritis affects about 7 million Australians if we incorporate arthritis and back pain together, and your vote matters. So we're trying to advocate to our federal politicians to do a little bit more about out-of-pocket costs for healthcare and to ensure that some of the programs that I was speaking about today are reimbursable and accessible. So this is the Arthritis Australia site, microsite, to help inform people about how they can identify who their local representative is, if they don't already know. It provides you a letter, so you don't have to do this, but essentially will give you a letter that you can then write to your local MP to try to enforce and encourage them to make sure that arthritis is part of their election platform, particularly as it relates to out-of-pocket costs and accessibility to some of the programs which we will be strongly advocating for. If you would like to learn a little bit more about the work that we're doing in the space of osteoarthritis, particularly those clinical trials and some others that I didn't mention today, that's the website and that's the QR code for our clinical website. And this is a creative video that one of my team put together to talk a little bit about some of the areas that we're working in the osteoarthritis space to improve, hopefully, the lives and the journey of people living with osteoarthritis. I'm fortunate to work with a wonderful multidisciplinary team and also a large collaborative network internationally. I'm well supported by a number of different funding agencies, and I'd like, obviously, particularly to thank them, in particular the National Health and Medical Research Council and Arthritis Australia, for the support that they give to me and the team that I look after. And now looking forward to your questions. And so I think in the interest of moving forward to that, I'm going to hopefully do this, and this should work. I drag that across to there. All right. All right. So I'm just going to try to take them in order. And if I see a question that's kind of repeated, I'll skip it. But if you don't feel that I should have skipped it, please type it in again. And I'm going to get to as many of these as I can. And my understanding is that I've got about 15 minutes. So here goes. So the first question is, does this supplement assist in other osteoarthritic areas? And so I assume that refers to the combination supplement that I showed, and that's the joint action care slide that I showed with the combination of boswellia, pycnogenol, and MSM. And there is no reason to think that it would be restricted to knees. There is every reason to believe that this should be operational. And hips, hands, and other joints. So there's no reason to believe that this would be restricted to knees per se, and we are testing it in other joints as well. Is there a medical center or medical practitioners in Victoria who practice the holistic approach to osteoarthritis, and where can I find a contact in Victoria for a holistic approach practitioners? Great question. I do a lot of work in collaboration with a group at the University of Melbourne called CHESM, so CHESM. And they have a lot of different resources that they're working on, both in Melbourne, but I think also to distribute more nationally. So that's the group CHESM, CHESM. And if you go to the University of Melbourne website and you type in either that CHESM or you type in the name Bennell or Hinman, who are two of the leading clinician researchers who work within that group, you'll hopefully find links to a number of different resources and clinicians who work within Melbourne and the Victorian community that hopefully you will be able to avail yourself of that. This is fantastic information. Sorry, but my husband and sister prefer to hear someone in person. Do you do talks people can come to, anything at local libraries or councils that run a lot of health talks? I would love to do more in person. So I do a lot of these talks. We're doing a lot more online now. So I do a lot, obviously, through both webinars and podcasts, through our Joint Action podcast. I would love to spend more time in the community. So please, do avail yourself of some of the resources that we do put online. We do community seminars 2 to 3 times a year, but they're run in Sydney. And again, I don't know where you are, but we're based at the Royal North Shore Hospital, and we do run regular seminars at Royal North Shore that we advertise through our social media. So it's the Osteoarthritis Research Group. So if you go there, you'll find some of the social media channels that we post to about some of the live events that we do on a regular basis. Next question is, you seem to have focused on knee pain, not back pain. So yeah, I mean, most of what I do is very much centered around osteoarthritis, and typically for most people who focus on osteoarthritis, we focus very much on knees, hips, and hands. And it's not to diminish the impact that back pain and other arthritic joints throughout the body may have. But the vast majority of people who have back pain, it's not related to arthritis. And there are a lot of great researchers in Australia, including in South Australia, people like Lorimer Mosley, but obviously also in Sydney with Manuela Ferreira and others who focus very much on back pain, who do a much better job and are much more articulate and intelligent than I'll ever be in talking about back pain. So I won't pretend to be an expert in that space. Does being overweight have anything to do with back, neck, or hand osteoarthritis? Great question. And it's not to say the others weren't great questions as well, but historically, I think everybody believed that osteoarthritis that occurred as a consequence of excess weight was due to mechanical load, and it was just a problem that you saw in lower limb joints. So for example, knees and hips. Interestingly, over the last couple of decades, we've become increasingly aware that carrying excess weight also has impacts on non-weight bearing joints. So if you carry excess weight, it increases your risk of hand osteoarthritis by about 30%. And we would expect the same for other joints in the upper body, the axial skeleton and the upper limbs. And so why is that? Well, it's in part because fat, or what we call adipose tissue, creates inflammatory molecules, or what we call adipokines, that create an opportunity for inflammatory damage to occur to joints that are otherwise not necessarily weight-bearing on a regular basis. So yes, being overweight does have an impact on other joints. Next question, is an arthroscopy useful to clean out the site of bone fragments? So every year, about 30,000 Australians have an arthroscopy of their knee for knee osteoarthritis. Less than 1 in 1,000 of those people have essentially what we call a locked knee. So an inability to fully straighten the knee because a bone fragment has got stuck in there. And in those particular instances, an arthroscopy may be helpful to remove something that's causing your knee to be locked in one position. And when I say locked, it's locked at about a 40-degree angle. So it's not locked just sort of 10 degrees shy of full extension. It's well bent. There is a hell of a lot more arthroscopy that's happening out there than should be happening. And so for the rare instances of people where they do have that locked knee as a consequence of a large fragment blocking any ability to extend, an arthroscopy may be appropriate. But for the vast majority of people who are having these, know that if I did a sham arthroscopy on you, namely I wheeled you into the anesthetic bay, I made a little nick in the front of your knee, well, I put you to sleep and I made a little nick in the front of your knee and made you believe that you were having an arthroscopy, you do at least as well in the clinical trials that have evaluated that as people who are having the real thing. People who have the real thing, it increases your risk of joint replacement, shortens time to joint replacement, and increases your risk of having a clot, an infection, and a slight increase in death. Has topical medication Voltaren gel been shown to be useful to reduce knee pain? Yes, and it appears, at least in clinical trials, to be similarly effective to the oral formulation. So again, topical anti-inflammatories, both for hand and for knee osteoarthritis, have been shown to be similarly effective to the oral formulation. I have osteoarthritis and osteoporosis. Are they connected in any way or don't affect each other? So if anything, most epidemiologic or community-based studies would suggest that there's an inverse relationship between osteoporosis and osteoarthritis, primarily thought to be the fact that if you have an increased bone density, meaning you're less at risk of having osteoporosis, your bone is less able to absorb the mechanical forces around your joint, placing you at greater risk of susceptibility of the development of osteoarthritis. So there's actually an inverse relationship between the two. They quite commonly co-occur, but if we look at the general community, they tend not to co-occur. Hi, David. I really appreciate tonight's session and that you'll send us the slides. I run a community group of older people, and some of them probably won't be able to watch this. Any chance you know of people who can come and talk to them about this kind of stuff? Lots of us have arthritis. So again, you know, very, very happy within reason to give these sorts of presentations. Very happy. I'm sure the group that I'm recording this for tonight will be very happy to share that recording, and within reason, happy to organize sessions like this again moving forward if we can recruit a large enough crowd. I'm scared to exercise when I'm in pain because I feel like it may make my osteoarthritis worse. Thank you for asking that question and your honesty. That's a really, really common concern that people have with osteoarthritis, and I think it's something we need to handle sensitively and thoughtfully. And usually what I say to people like yourself is that what we call fear avoidance, so that fear that you're going to hurt yourself if you go out and do something, is something we really need to tackle head on. And you need support. And usually for me, that support is I work in parallel with physiotherapists or exercise physiologists who help to support a person in gaining confidence, gaining strength, and starting to relearn some of the things that they think may actually be going to cause them damage. Oftentimes in the first instance, that exercise is supported, right? So we might get a person to start doing some exercise in a pool or on a stationary cycle, and over time, gradually introduce some weight-bearing exercise to improve their strength. And as they get stronger, build confidence that there's a lot more that they can do in terms of land-bearing exercise like walking and so on. But ideally, you know, work in tandem and partnership with someone who can help you through that process. Don't try to do this alone, because a lot of that support is so important to making you empowered in that journey. But don't you know, use the couch as an option. I know you're not doing that, but don't use the couch as the remedy to getting this better. What is your opinion on the use of medical cannabis for arthritis relief, please? Again, a great question. One that we've done a study on and that we're hoping to do another study on, because I do think it has potential. But if I'm being completely honest with you right now, I don't have the evidence base to support that statement. Okay, so we don't have clinical trials in osteoarthritis demonstrating unequivocally that medical cannabis is helpful for pain in the context of osteoarthritis. There's a lot of mechanistic reasons to believe that it would be, but I don't currently have a clinical trial that speaks to that. So I'm not going to advocate for it, particularly in the light of the costs associated with the use of medical cannabis. I find it hard to find the correct exercise as I have osteoarthritis as well as fibromyalgia and spinal stenosis. What is the best thing to do? So again, a great question, because these comorbidities, so these diseases that often travel hand in hand, are really, really common and often creates great challenges about what to do in this particular problem. And again, my answer is probably not going to be that much different to the one I gave it a moment ago. Find a wonderful team to help support you through that process. One resource that I would advocate looking at is the Australian Physiotherapy Association website. So that's the APA. And they have a function on their website called Find a Physio. Musculoskeletal physiotherapists are oftentimes great partners in helping shadow and show you through the process of personalizing and targeting treatment according to ideally what you should be doing. It's not one size fits all. Is there a place for methotrexate in the treatment of osteoarthritis? So great question. It's a controversial one. And at least at this point in time, there does appear to be a small effect in people that have a more inflammatory version of osteoarthritis from the use of methotrexate. Difficult to know honestly how to use all of that evidence base at the moment. And it's something that I'm getting a colleague of mine to write an editorial for at the journal at the moment, primarily because there are some supportive studies with very small effects in a limited subgroup of people that have osteoarthritis. So it's really hard to disseminate that knowledge with the trial evidence that we have at the moment. All right, I'm running out of time. So for everybody who's typing in questions, thank you. Thank you for your talk. My name's Peter. I'm a radiation oncologist with an interest in treating benign disease, so non-cancer diseases, including osteoarthritis. Would you believe in Germany, 1 in 3 patients who receive radiotherapy are treated for benign disease? There's an emerging randomized evidence as well as multiple large institutional case series showing a benefit with low dose radiotherapy. Can you please comment if you think this is worth pursuing? To be honest, Peter, I haven't seen the evidence. It's not something we're actively pursuing. There's a lot of interest in a thing called radiofrequency ablation, but I assume that's not what you're referring to. Yeah, so I can't really comment any further. Sorry. Thank you for tonight, David. Great to see you highlight the importance of education in osteoarthritis in the arthritis space. Thank you. Joint action care. What do you recommend for hand arthritis? So thank you for the question. So a couple of different resources I'll point you towards. So one is the Joint Action podcast. I had a wonderful conversation with Marguerite Kloppenberg, who's probably one of the world experts in hand osteoarthritis, about different options available for hand arthritis. So that's one option. The other option is to look at, we did a trial called COMBO, so COMBO, which was published in a big American journal a few years ago, particularly for people with base of thumb osteoarthritis, but there's no reason to think why that would be different from other treatments for other types of hand osteoarthritis, where we looked at the combination of a topical anti-inflammatory, specifically Voltaren gel, in combination with a neoprene splint to support the base of the thumb, some therapeutic exercises to improve range of motion and strength, and also activity modification. And so there's some great resources that are available through the MyOA website with regards to OA management that typically takes into account that type of evidence from evidence base that we've created. So there's lots of options that are available to you. And I guess the main message I want to try to get around tonight is really empower yourself, be proactive about the management, because there is a lot that you can do. I'm going to have to apologize because there are so many great questions there. Sorry, just one question. So the joint medication you gave is expensive, so $40 for 60 tabs. So that's, I guess I'd encourage you to, and again, it's not my company, you do with it what you want. So that's for the joint action care. So that's 2 tablets daily for a month for $40. If you go down to the chemist and you buy, equivalent type of supplement, you're going to be paying a lot more. All right. So in the interest of time, and again, huge thank you to all of you, firstly, for coming along and for the great questions, and apologies that I can't get to all of those wonderful questions. This recording will be available. My understanding is it'll be available through the website and made available in a few days after the show. So again, thank you so much for your time. It's a great privilege to spend a little bit of time with you this evening. And again, empower yourself, be proactive about managing your osteoarthritis, and hopefully your journey with this disease will be one that is much more tolerable and enjoyable with greater function as a consequence of doing the things that I spoke a little bit about tonight. All the best, and thank you so much for your time. Good day.